So we are back again with another interesting webinar series. So let us commence the third webinar of KSOGA, Gyanadeepa series, under the esteemed guidance of our beloved President KSOGA, Dr. Durgadas Astrana sir.
Sorry, Srimati, there is an echo. I think you have logged in two devices.
Yes, not Srimati, Suvarna.
Suvarna.
Ma'am,
There is an echo.
Is this better now?
Yeah, better.
Yes, to talk, we will know.
So let us commence this third webinar of KSOGA Gyanadeepa series under the esteemed guidance of our beloved President of KSOGA, Dr. Durgadas Asrana sir. His visionary leadership and constant encouragement continue to strengthen our academic endeavors, and this webinar series stands as a testament to our commitment towards continued learning, collaborative growth, and excellence. So let's seek divine blessings. So maybe can we have invocation song, Mr. Arun, please?
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Good evening, everyone. Sir, Shobha ma'am is yet to join.
Yeah, we'll proceed. As soon as she joins, let her say her good words. Okay?
Yes, sir. So shall we have the chief guest then, sir? We have Bharati ma'am, Rekha ma'am, they have joined. Or shall we have the talk, sir? Which one?
No, we'll start with the routine. We'll introduce and respect the chief guests, all the four.
The chief guest.
Okay? Jyoti Bangla will join from the airport, it seems. Okay? Routine.
Arun, CV share ಮಾಡ್ತೀನಿ.
Good evening, everybody. I am Dr. Durgadas Asrana, President of KSOGA. Welcome you all for this KSOGA Gyanadeepa series. This is the third in the series. And this is to link KSOGA with the other states. And we have started with Gujarat. This is the third. First, I selected Gujarat because there are so many stalwarts in Gujarat with such a rich knowledge, which KSOGA also wanted to listen to. So, with these few words, today I invite the four chief guests. The first among them is Dr. Neba Mohan. She is the chief consultant in Renu Maternity Center, Patna, Honorary Secretary of Patna OBG Society in 25-26, Chairperson of Breast and Peripheral Health Committee of FOXY 26-28, and she was the past treasurer, clinical secretary, joint secretary of Patna OBG Association. She is the clinical secretary of Vaginal Surgery Committee of Bihar and Jharkhand chapter, and so many accolades. The most respected part is she is busy today. Just 5 minutes back, she called me and told she has to attend one meeting. I requested her to bless us in this evening before leaving the meeting. Madam, I am really grateful. KSOGA is really grateful to you for even in the busy schedule hours you have joined. The KSOGA wants to listen to you. Please say a few words.
Thank you so much, Dr. Durgadas. I must say that I am deeply attached with many members of the KSOGA. You are one of them. And at the outset, I must thank you for having me here at this scientific event of KSOGA, Gyanadeepa webinar. And this is the third series of yours. So congratulations for conducting such scientific sessions. And the intentions are really scientific and good with having, at the outset, my namaskar to respected Sir Pankaj Desai, sir. My gratitude to you, sir. I'm a big fan of you. You know that I've been following you all your workshops and all your talks and everything in all the AICOG right from the beginning in the 90s when I used to join AICOG. Since that days, I am following Sir. So one of the biggest fan of him. So my gratitude to Sir. And I must thank all the speakers, Dr. Neeraj Yadav, and my best wishes to all the team, KSOGA team, the president, the secretary, all known to me. I've worked with Dr. Shobha Gudi, a boss for me, with other committees like Family Welfare Committee. When she was chairperson, I worked with her as his zone coordinator. With Rajshri Paladi also, I worked with other projects. And I must confess that the guest word is okay with me, but chief has been added additionally with Dr. Durga Das, and I'm honored to be guest only. So please let me only the guest for this event. So my good evening to my other friends, Dr. Jyoti Banglowala, Dr. Rekha, Dr. Bharati, all we are working together. So lots to go for this event. Best wishes for this event, and my best wishes, Dr. Durga Das Asrana sir, for your upcoming whatever upcoming event for you, upcoming election. My best wishes. We are all with you, and I think it should go best for you. So best for today and best for the upcoming days. With these words, thank you everyone, and thank you for having me here once again. Thank you.
Thank you, Dr. Niba Mohan. Thank you. Now I
And,
invite.
Dr. Shobha has joined.
Shobha has joined.
Dr. Shobha.
Hello, Dr. Durgadas.
Yes.
Hello, good evening to
Yes.
everyone. Good evening. Sorry, I was delayed and I was driving,
Dr.
so I
Shobha,
took a few
before I
minutes.
leave, I must say a very good evening and regards to you also.
Yeah. Niba, it is wonderful to see you in KSOGA. Welcome to Karnataka. Welcome to KSOGA. Very warm welcome. Okay.
I'm deeply involved. So many from KSOGA. So
yeah,
it's really
and now
nice
it is
to-
our turn to support your committee work. So all the best for your future endeavors in your committee. And and Dr. Durgadas at the outset, I think it is very befitting to salute and honor our past president Foxy, Dr. Pankaj Desai. And sir, हम लोग सब तो आपके बहुत बड़े फैन हैं सर. आप तो टीचर ऑफ टीचर्स, हम सबके गुरु हैं. And it is so lovely that you have consented to come today. KSOGA is indeed blessed. And I can see that the topic chosen also is much needed one. And I'm sure 100% each person who joins will benefit with your volatile way of dealing with this. Even I am very eager to listen to you. So I will not delay this much. And I thank Neeraj for coming on. Neeraj is going to be my, fellow VP next year. So it's wonderful that he is coming and building a platform for South. Very nice to see. Bharti, so wonderful that you are here in spite of your busy schedule. And of course, the President-elect Rajeshri. Amrish, I am happiest to see you. Welcome to good health forever. Welcome to good health. Okay. All right then. So with that, I will hand over back. And Dr. Durgadas, I got a little carried away. They said more than a secretary should. Thank you very much for the time.
Thank you, Dr. Shobha.
Thank you, Dr. Durgadas.
Now it's my privilege to introduce our dear Dr. Bharati Rajshekar. She was the past president of KSOGA from whom I have taken the charge. Presently, she is the chairperson of Foxy Perinatology Committee. Lot to tell about her.
Dr. Durgadas, I think
Yes.
we will move on.
Yes. Only few things I have to say is, one is you have during your presidency of your Hasan Society, the number of prizes you have bagged of Foxy prizes your committee has taken is I think is a landmark. None of the committees, none of the local societies can achieve those awards that you can read in the biodata. And of course, I have taken the charges from you. Probably I am doing the good things what you have started. And with these words, over to Dr. Bharati to say a few words.
Thank you, President Dr. Durgadas ji, and my pranams to Dr. Pankaj Desai, who is the guru, and I think a very apt choice for the Gyanadeepa series because earning jnana, you have to be very, very lucky to have a guru who can impart his jnana to his followers. And as Dr. Niba said, from the days of my postgraduate days, I have been an ardent listener of Dr. Pankaj Desai, and I'm fascinated by his presentations, his knowledge, his humility and humbleness shows how learned he is. And I think his YouTube channels, his publications are a must for all the young obstetricians and gynecologists because they are a stepping stone for a ethical and a very protocol based practice which we can inculcate in. Thank you, Dr. Pankajji, and indeed, KSOGA is blessed to have you here today. And you have chosen such a wonderful topic because adolescent health, they are the future of our society, and we believe that we have to nurture the future. This has been my theme for the Foxy Perinatology Committee, and Dr. Pankaj Desai is leading it and saying, unless you see that your adolescents are healthy, we cannot improve our maternal outcomes, our reproductive health outcomes. Neither can we reduce the incidence of NCD, which is looming large at all of us all over the country. So thank you, Dr. Pankaj. And the other talk, psychosexual management of psychological disorders. I think this is going to be an eye opener, and we have none other than the stalwart of sexual medicine in Foxy, Dr. Neeraj Jadhav, who will be addressing this topic. And I think all of us clinicians need to have this little concept of talking about psychosocial health to all those who come to us, because they come to us with very vague symptoms sometimes, and we try to very cursorily tell them nothing will happen, you do yoga, you do. But when you sit down and speak to them, the root cause could be a sexual disorder in the couple, and that could be the reason for their upsets and their disharmony or their health issues. So I think we all need to use this in our clinical practice. And I thank Dr. Durgadas for giving me the opportunity. And as rightly said by Dr. Niba, we are part of KSOGA. We are not chief guests. And Dr. Durgadas carries the baton. We had Gnan Sangam. During my term, we had Gnan Sangam, and now the Sangam has become a Deepa, and let this Gnan Sangam flow to all the parts of our country. And at the same time, I would wish Dr. Durgadas all the best in his future tenure, because we want more people spreading Gnan and more people getting into Foxy to lead the way for years to come to all those people who are following or who are junior. I would not say following us, who are junior to us, and we have much to learn from them, and we have a little to teach them also. Thank you for the opportunity, and over to you, Dr. Pankaj Desai.
Thank you, Dr. Bharti. Thanks for the kind words. I acknowledge the presence of Dr. Sheetal, even though in her busy schedule she is here. Madam, thank you for joining. I was asking Srimati whether Madam has joined or not. Sheetal Madam, I am really honored that you have joined now. Coming to the next chief guest is Dr. Jyoti Banglawala. Whether she has logged in? Jyoti Banglawala, she is a chairperson of...
Is she there? She don't see her.
No, she told that she will be in the airport. Okay. I will introduce her in a few lines. If at all, I will call her. She is the chairperson of Ethics and Medical Legal Committee of Foxy. She is a medical legal advisor. She is the past president of Indore OBGY Society 22 from 22 up to present. She is the secretary of Indore OBGY Society from 21 to 22 and treasurer of ICOG and lot in the list. I welcome Dr. Jyoti. If it is possible to join, I know you are flying. If it is possible, kindly join us at your leisure hours, please. The last, our own Dr. Rekha.
Yeah, thank you. I'm here.
Dr. Rekha Rajendra is our own girl. I don't know what to say about her. She is the first rank holder in MBBS and 7th rank in DNB. She is the...
no, that's okay.
That's okay. She was the president of KSOGA. The latest thing is yesterday she has won the KISA EC elections in the thumbing majority. She was the maximum voter she has won with the maximum votes. Rekha,
Thank
few
you.
words of wisdom.
Yeah, thank you so much, Dr. Durgadas, first of all, for inviting us. And as Dr. Bharti said, we are one among all the KSOGians, happy to be part of KSOGA. Happier because I'm sharing the platform with stalwarts like Dr. Pankaj Desai, sir. Sir is a pioneer and sir has been guide philosopher for me too over so many years. Also, the august presence of Dr. Ambrish Bandiwad has enhanced my pleasure. I also share the platform with my colleagues, Dr. Bharti, Dr. Shobha, Dr. Rajashri Paladi, another good friend of mine, Dr. Srimati, etc. Dr. Durgadas, thank you so much for inviting us here. Actually, right now at 4 p.m. only, I had another concurrent meeting with Dr. Gyanadeepa online, but I said Durgadas sir is first, so I should finish that. So that way, I'm happy to have you always associated with me. Dr. Durgadas is a very active KSOGian since I know him since long time. Did lot of good work. He has improved the platform which already the other pioneers, the presidents like Dr. Bharti had done a great work, and he has improved on that, especially in the scientific terms. In the sense, he doesn't leave any chairperson and ECs sitting idle. He wants all kinds of programs, be it laparoscopy, be it ultrasound, fetal medicine, vaginal surgeries, anything. The chairpersons have become so active that almost every day we have the KSOGA platform webinars on the platform. And there were other so many physical programs also. And on 10th, we have always every month without fail, we have on 10th, 9 to 9:30, the president's speech that goes right on the clock. And we have regular EC meetings. Everything is so well programmed. The annual day KSOGA at Tumkur was a real benchmark in terms of scientific rich content as well as the cultural part. All of us enjoyed cultural programs also very equally. And he's done a lot of pioneer work in the safe motherhood. He is an experienced person in that subject. And I feel all of us KSOGians and all the Karnataka voters and even outsiders should support him, because I feel he's the right candidate for this committee. He's going for Safe Motherhood Committee, requesting all those who are here and even those who have not joined, through word of mouth, let us spread and support him heartily, his candidature, that he wins. My all best wishes are with you, Dr. Durgadas, for the coming election as well as in future. Thank you so much for the opportunity once again.
Thank you, Rekha, for those kind words. Now over to Dr. Srimati for the scientific session. Before I hand over, Pankaj Desai sir, my deepest gratitude that you have accepted my invitation. There is no, I cannot say in words. Really, I am telling you, while I took the phone to call you, asking for your permission, I was really, sir, I was very much nervous whether you will accept my invitation. We are all people in the ocean, and we are really honored by your presence. The way you speak to us, the way you make us comfort, and that's the reason I thought we should not have any panel discussion or anything. Everybody should listen to you. That with that intention, I made only 2 talks. Sir, I'm really honored by your presence today. With these few words, over to Srimati for this
Thank you, sir.
scientific
Thank you,
event.
sir. Yeah. Good evening to everybody, and thank you to all the chief guests, and of course, Pankaj sir and sir. Dr. Swarna will be introducing the first chairperson, and then Pankaj sir will be his final chair. Thank you, Dr. Swarna.
Yes, thank you for those inspiring words to all the chief guests. With that, we now move to the scientific session, the heart of the today's program. So let us begin with our first presentation. May I now invite, and the topic is tackling adolescent concerns from a gynecologist angle. May I now invite Dr. Sheetal Thalekar madam to chair this session and introduce speaker Dr. Pankaj Desai sir. Dr. Sheetal Thalekar madam is president of Vapi Society, and she is a consultant OBGYN at Shalby Multispeciality Hospital, Vapi. Welcome to the session, ma'am. Kindly introduce Dr. Pankaj Desai, sir, ma'am.
Thank you so much. I'm truly grateful and humbled that you have given me this opportunity to introduce a stalwart like Dr. Pankaj sir, which needs no real introduction. Everybody here, including me, is a big fan of sir. And I like to say few words about his profile. Sir is a consultant OBG specialist at Janani Maternity Hospital, Baroda. He was a former Dean Student Association, a professor and unit head at Medical College, Baroda. Sir has given more than 65 orations. He had more than 186 guest lecture. He was a guest lecturer, moderator, and panelist at various academic sessions. Sir has 108 publications to his name and more than 9 research paper awarded to him for the best paper prizes. Sir is a best author of more than 13 books, and one of the book he had been to Vapi and has personally signed it for me. So that was a biggest fan moment for me. So thank you, sir, so much. As Madam said, that YouTube videos and blogs are really very worth watching, and we learn a lot through your video sessions, YouTube and your vlogs. I would like you to. I'll welcome you to this session, sir. Thank you so much.
Thank you, Dr. Sheetal ma'am. Over to you, Dr. Pankaj Desai, sir.
Can I share the screen, please? Hello, can you hear me?
Yes, sir, you can share. Yes, sir, we can hear you.
Okay, thank you. Okay, can you see now?
Yes, sir, we can see, but it has to be full screen.
I'll come to full screen in a short time, please. Now, can you see the full screen?
Yes, perfect.
Okay. I will take a second to settle because now I'm very comfortable with new technology, but yeah. Honorable President of Karnataka Society of Obstetricians and Gynecologists, Dr. Durga Das, really honored, really thankful to you. For a teacher, getting an opportunity to teach is enough. Is enough. His life goes on. And if you will give me an opportunity to learn and teach, even after I have died, and you put me on the cremation pyre, I will get up and learn. I don't mind. Dr. Bharati, Association of Decades, Dr. Rekha doing so well. Very brilliant lady. Don't need to know that she stood first here and seventh here and this. We can make out from her work. So wonderful. Dr. Niba trying to find time. I'm always free between 4 to 6. So don't worry. I am not busy at any other airports. I'm not busy meeting with anybody. A busy person is he who has time for everything. Because they say that don't let time manage you. You manage time. Dr. Amrish, your name is here. I will not speak. If I will speak anything about Dr. Amrish, it will belittle my friendship. It cannot do justice to my friendship with and all what my association with Amrish is for decades now. Dr. Rajashri, I am seeing your work. Very nice. Dr. Srimati, introducing us well. And Dr. Neeraj. I had a good fortune of working shoulder to shoulder with Neeraj. And let me share here one very personal matter. When my nephew had a very bad condition and we lost him subsequently after some years, Neeraj donated blood for my nephew. So that is his greatness. It is not only in his work, but I am obliged by Neeraj in blood by that gentleman. And that is his goodness, which you will never come to know. And of course, Dr. Shobha Gudi and all of you who are here, Rajashri Paladi, I know you for such a long time. Thank you so much. Yes, as usual, we will start with a prayer. I hope everything comes through smoothly. May all beneficents bring peace to earth. With this, we start a very vast topic. From one end to the other, I had to milch down as to what I should take and what I shouldn't. And we all know that adolescent problems are tough problems. They are not just only because they are very young and immature. They are really tough problems, and we will handle them scientifically without getting emotional. And so, let's go. I'm going to keep in a situation analysis format so that you can imagine the answers in your mind and then compare it with what answers I give. Tackling adolescent concerns with a gynecologist's angle. So often I see my wife reassuring. My wife is also a gynecologist. Those of you who know Amrish and all know. So often I see my wife reassuring the mothers of adolescent subjects coming for help for irregular menstrual cycle. Don't worry, this is an expected pattern, is many times her standard answer. I asked her, which all patterns do you call an expected pattern in this age group? Say perimenopause also, so many times we say this is an expected. Heavy bleeding in perimenopause is never normal. Here, let us see what are the normal patterns. The first one, less than 1 year post-menarche if she is there, irregular menstrual cycles is a normal pubertal transition. It is a normal variation, please. No need of doing anything. However, if she is more than 1 year, but less than 3 years post-menarche, then if she has less than 21 days cycle or more than 45, investigate, please. This is worth investigating and managing. 3 years after menarche, less than 21 days, and this period comes down to more than 35 days, or if she has less than 8 cycles per year, please investigate and manage. And across the board, what about primary amenorrhea? Because both sides we require investigation, heavy as well as less. If there is a primary amenorrhea by the age of 15 years or more than 3 years post-thelarche, we know what is thelarche, breast development, please investigate. Till then, keep your patience. And this patience, I'm going to, if I can give you only one message for this lecture, it will be patience. You require it everywhere when you handle these problems. Our society is developing. There is no doubt about it. And there is one effect we are seeing on adolescents, adolescent menstrual patterns in the developing society. Let us see what it is. I know many of you must be knowing this, but never thought that this, may not have thought, not all, may not have thought that this is because the entire India is developing. This is the effect taking place on the adolescent girls. Let us see. Nowadays, many mothers seek appointment of gynec as their daughters seem to have started menstruating early. Sir, I started menstruating at the age of 13 and she is only 11 and she has started menstruating. What is happening? This may be as early as 5th or 6th standard of their class, around 11 to 12 years. Is this normal? And why is this happening if it is really normal? I will give you an example of 2 similar countries which has a similar problem. South Korea and China. South Korea and China, there is a historical decline in their menstrual age. The average age at menarche dropped from 16.4 years in women who were born in 1902 in China and South Korea to in 1942 to 14.4 and currently to 11.8. See this, please. This is the difference from 16.4 to 14.4 to 11.8. So don't start jumping. Discuss the effect of advancing prosperity of the society and education with her, and she will, and her mother will come at peace, come to peace. Friends, there will be a limit. It will stop at some time. Maybe around 11 years it will stop. It will not further fall. This is physiology. And so please, if your patient comes with that she has started menstruating early, please don't start jumping. This is something which is occurring all over India, and this is the price you have to pay. Whether it's a price or it's a sign of development, I leave it to you to decide. Now, one misbelief, and I put it in a clinical situation. She was my friend's daughter, so by right she calls me uncle. Uncle, see, I have started menstruating now. Now my height won't increase. I am sure I want to grow more in height. How true is her belief or misbelief? It is an absolute misbelief. Nothing is different. They are different systems and nothing will happen. She will achieve her potential height, if not her genetic height. We will not go into that discussion. But a genuine apprehension now I am going to discuss. It's a clinical case. Please, you can start thinking as to what is happening and why this is happening. Others of her age stopped bleeding in 2 to 3 days, sir, said an anxious mother as she walked into our consulting rooms. She bleeds every time for 8 to 10 days, while others are bleeding only for 2 to 3 days. This time, sir, she just goes on spotting and bleeding, sometimes heavy for now 1 month or so. I thought in my mind, could this be a bleeding diathesis? And how to handle it if this is so? At this age, what will present as this type of menstrual pattern? Von Willebrand disease, platelet function defect, thrombocytopenia, and clotting factor deficiencies. So heavy menstrual bleeding, please include this. Most of the times these are picked up on routine investigation. Get it done and be aware and alert to this aspect in the report. Friends, approximately 50% of adult girls with bleeding disorders present with heavy menstrual bleeding at menarche, and brilliant gynecologists like you diagnose as early as that, and quite a few get diagnosed later on during pregnancy, though she might have gone to many physicians in between. Others, however, may not present until their cycles become ovulatory. Right from anovulatory phase, she starts bleeding heavily. Or, as it happened to me, one of the patients just 1 week before, recurrent hemorrhagic corpus luteum. I do a sonography and find a hemorrhagic corpus luteum. With or without rupture, or with or without hemiperitoneum, with ovulation, also can be a gynecologic indication of a bleeding disorder. I am sensitizing you to these adolescents who will have this type of presentation. Anemia that results from this bleeding can cause associated symptoms of headache and fatigue, and our country obstetricians are masters in this anemia. I will not go into details. However, this is the time to be alert about adolescent anemia. We are not only discussing, predominantly it will be a gynecologist's perspective, but from that also, a young lady with adolescent AUB, essentially hormonal, presents to you looking pale. On viewing her reports, it was found that her hemoglobin had plummeted to 6. Now, this comes from an obstetrician who comes from a very high anemia part of the country. Gujarat has high anemia, many reasons, of which Baroda district, my district, is one of the highest anemia incidences. Therefore, I am sensitizing you. It is possible that Dr. Bharti or Dr. Amrish may not see it so often, but you pick up 6 grams of woman presenting with AUB, which is hormonal. You are competent in handling our hormonal disturbance. You are masters. That is what we are doing since our MD. How to handle our anemia. Anything special? No. But involves a combination of iron-rich nutrition, lifestyle adjustment to manage rapid growth, and control her menstrual blood loss. Please, don't only concentrate on anemia correction. Even they say that consuming tea and coffee consumption during meals is now not advisable. Many people, out of the images of or the vestiges of the British who always have tea or coffee after dinner, it comes in the way of these adolescents rising. I'm giving you this a little different message. So key actions, just a quick revision: consume iron-rich foods, taking iron folic acid tablets, and threatening iron blocking habits, if any. This you have to do in your consultation. Now, this next case is going to challenge you doubly. For an average gynecologist, it is a single challenge. But for those of you who are brilliant and therefore attending this type of sessions, those who think that they know everything, they did not go to this type of programs which people like Durga Das are working so hard to build. But then, because you are here, you will realize why it is a double challenge. A typically anxious mother walks into consultation room with complaint that her adolescent daughter overshoots her expected date of menstruation, then bleeds for 10 to 15 days. Fine. Not very uncommon, nothing exciting about it. But the episodes are occasionally quite heavy and she has to miss her school and tuitions. Nowadays, this is unbearable, understandably. Currently, she is on her 8th day and is still bleeding quite heavily, sir. We did her ultrasound, and what did we find? Nothing great. Uterus, normal in size in TS and LS both. Right ovary normal, there is a developing follicle there. Left ovary also normal, supporting the right follicle. But here comes the answer. Her endometrium, even on the 8th day, is 10 mm in size. So, it is a mischief of the hormonal problem. Estrogens, which cause thickening, are at play. Now, we all know that estrogen and progesterone are two reins of a horse. And one, if estrogen goes heavy, the horse turns this way. If progesterone goes heavy, the horse goes this way. Both are supposed to maintain a balance. But you have two challenges now, and therefore, the point. First is immediate arrest of bleeding. She is bleeding heavily for 8 days. I am reminding you. And then, maintenance hormones to counteract the unmitigated estrogen playing a havoc with her endometrium. At present, she is bleeding, that is her problem. And secondly, her endometrium, which is 10 mm, requires to be neutralized. So there are two problems on hand. I know an average gynecologist will give progesterone and it is over. But my question to all of you is, and going to make you think, which progesterone we should use? 19-nor testosterone derivative progesterone or norethistron, or 19-nor progesterone derivatives, progestin, medroxyprogesterone acetate, or either, doesn't matter. Think by the time I gulp down a sip of water. For an average gynecologist, either doesn't matter. But how can you differentiate one prescription from the other? And it is not only the prescription, the entire approach of that gynecologist, you can make out how brilliant these people must be. It differentiates you out. Friends, understand this. For immediate arrest, testosterone will work. Testosterone-derived progesterone or 19-nor testosterone derivatives, this is what you will give. Break. I will not give the dosage and schedules. Wait for the withdrawal and then after start for maintenance, other progesterone, 19-nor progesterone-derived progestins, medroxyprogesterone acetate. Not one for the other. Both are exclusive. If you can differentiate, this webinar was worth attending. This is one more message which I wanted to give. We now come. So up till now, many times we prescribe any progesterone. No. Look at the pattern, that is history and clinical features, and look at the sonography picture. On that base, your answer will be the professional management of that adolescent girl. Currently, lots of discussion is taking place on this. I will not be going on and on, but this is worth discussing. And there are so many misbeliefs and misapproaches which are taking place due to probably lack of clear differentiation messages given by the teachers. Because the student never fails, a teacher fails. Miss SS, 15 years young girl, who overshoots her expected date of menstruation and then bleeds for 10 to 15 days. These episodes are occasionally heavy. She looks plump. Answer is in front of you. Her mother attributes it to her junk food liking. You notice a faint line of hair on her upper lip. And her USG picture I'm going to show you is this. A telltale picture. You can see the other ovary also. This is adolescent PCOS. Friends, let me share this with you. Adolescent PCOS related any video which I import gets hundreds of hits in a short time. That means there is an alertness and concern not only amongst the obstetrician and gynecologists like us, but also from common people. They are also concerned about it. One of my patients in last morning's consulting, she came and sat down and said, "Sir, we are planning she is not adolescent. She is planning a pregnancy." And I said, "Beta, how many years have you been married for?" She said, 4 years. "Any investigation done?" "No, sir. We have not nothing." But still she uttered a word, "Sir, I have PCOS." So much it has gone deep. How she knows and all, we will not go into it. But PCOS is something. Is the incidence rise real or apparent? None of our business for this webinar. I can give a lecture on this, just as I told you about how the age of menarche is reducing, the societal concerns, societal reasons. The same way, there might be answers for that, but we will not go into this. Handling this is important, and scientifically handling this. Handling AUB of PCOS in adolescents. I want to give this clear message. In adolescent, PCOS should not be diagnosed unless both irregular menstrual cycle and hyperandrogenism is present. Both of them should be present. I am not bringing in sonography anywhere, and I will tell you the reason. Absolutely clinical. Both of these will be absolutely clinical. You can pick it up. Don't jump to sonography. Everything sonography. Here there is a limitation. Sonography is a miracle which God has given us. Many times when I am doing an early scan, many times when she sits on the yolk sac, and so many functions of yolk sac are now becoming apparent, I talk with her. I don't require to go to any temple or a mosque or a church. I look at the yolk sac and go home and read sometimes about yolk sac, and you will realize that that force sits there on the yolk sac. It's a great blessing, sonography, but there are limitations, and we'll be coming to that in the adolescent patients clearly. At what age can we be confident of our diagnosis of PCOS based on clinical history? I am giving you 3 situations. Try this quiz time. Miss A, 10 years of age, has irregular menstrual cycle, menarche for 1 year, family history of PCOS. Will you start investigating for PCOS? Think. Miss A, 13 years, irregular menstrual cycle, menarche for about 4 years. Should we start, not 4 years, less, about 2 years. But even after 4 years, even if it is 4 years, should we start investigating them at such a young age? And last, Miss A, 18 years of age, has irregular menstrual cycles, menarche for about, say, somewhere around 7-8 years. Should we start investigating for PCOS? The answer, only one is right, and that is the last one. So wait until how much? I'm coming to that. There are evidence-based guidelines. Our parent organizations are doing. A confident diagnosis of PCOS in adolescents can be made 8 years or plus after menarche, not before that. Please don't label her, because the ovary is undergoing a phase of transition and therefore certain changes are common. At this point, the hypothalamo-pituitary-ovarian axis is considered as mature. What I mean is 8 years or more after menarche, and the diagnostic criteria align with those used for adults. That means the Rotterdam criteria which we routinely use. So, I am not using ultrasound anywhere, please. Is this a time to investigate? Yes. 18 years of age or more, this is time to investigate. What about ultrasound, sir? Why are you so much? Because you can make a mistake. You can surely make a mistake. Therefore, these CMEs are there. You know the basic. You know the theory. But where you can commit a mistake, that is the reason why CMEs are held. I always ask this. That what is the purpose of teaching programs even so many years after I left my formal learning, nearly 40 years before. Still I continue to learn at least 1.5 to 2 hours every day. Why? That is because to learn my limitations. I remember one cancer surgeon telling, he had come for an oration to Baroda. He said, when I was young, I always used to ask, why not to operate? Now I ask, why to operate? This comes from PCOS. You may make an unnecessary overdiagnosis and she will carry that label all throughout her life. And that you all know is not because of her. PCOS doesn't occur because of her. It is because of her mother, grandmother, somewhere. And therefore she got it. And poor girl, the way I have seen mothers firing the daughters even in consulting rooms. So USG for PCOS in an adolescent, where the latest recommendation states that gynecological age of more than or equal to 8 years or chronological age of 20 years. 20 years. That is when the maximum ovarian volume has steadied. And that is where it is wise. Before that, is it wise? This gentleman tells us no. Before that, no. With USG not being recommended for diagnosis of adolescent PCOS, now what do we have in our hands? Oh, you became a clinician first. I am repeating. I am a big fan and a big follower and a big bhakt of ultrasound. Sonography in all forms. I have given an oration based so much on ultrasound at Amrish's place on something related to preeclampsia some years before. Right? But here, our limitation comes. So how do we die? Clinical hyperandrogenism and laboratory hyperandrogenism. These are the two pillars on which your diagnosis will be based vis-a-vis PCOS in adolescent is concerned. Clinical hyperandrogenism is how do we diagnose? There is no evidence-based guideline available, and therefore your clinical sense comes in. And the consensus recommendation is severe acne and hirsutism. On standardized visual scales of hirsutism, the modified FG score with a level of more than or equal to 4 or 6 means more than 4 but between 4 to 6 indicates hirsutism. And we know this score. If need be, pull out today, go home or pull out your system and see what is it, quick revision, and you will be able to. What about laboratory, sir? For lab diagnosis, there are 3. Thankfully, labs will give you, I'm not boring you with the normals in bracket here because you will not remember, but the labs give you the normal. Recommended is calculated free testosterone, free androgen index, or bioavailable testosterone. Any 2 out of 3, usually free androgen index is something which is people are relying on. So on these 2, one is clinical and one is laboratory, and in clinical also 2, acne and hirsutism, you will diagnose as PCOS. And start taking steps. And what steps? Lifestyle interventions. Medication comes afterwards. This is one condition where the treatment is in that girl's hands. And not only in the girl's hands, it is in the entire family's hands. I will tell you what. Healthy lifestyle. The father and the mother are not doing any form of exercise. And they expect the girl to have a healthy lifestyle and hit the gym. This doesn't happen. Becomes very difficult for them, and then they abuse them, criticize them, fire them. You also join. They are eating foods which are rich in calories. We all know about it. We are not going into that. The whole family is eating shrikhand or jalebis for we Gujaratis next to her, and they expect her not to eat. The entire family has to adjust and have to take this as a challenge. Prevent excess weight gain, because weight gain is number one priority and the knee-jerk reflex of the family. Avoid waiting until obesity has developed, where lifestyle interventions alone are unlikely to reverse. So please, the whole family has to work. I know one family. Those of you know him, I think many of you know him. Dr. Deepak Bagde from Jamnagar, a dear friend of nearly 30 years now. He told me of a family where all the food items which are for snacking are either not purchased in a family, or the jars are converted into aluminum or steel jars so that nobody can see what is inside. When you are hungry or you are not doing anything, you see something attractive and you gulp it and you start chewing it. These are very important small things. I don't waste time in small things, but these are important small things. Whole family has to cooperate, and then that girl will not be unnecessarily harmed or alarmed or abused. So multi-couple components: diet, less sedentary behavior, exercise, and behavioral strategies. I am very, very much empathic to her, because I am also at that age of life, not adolescent. But for us, at this 60 plus age, diet, exercise, and sleep, these three are most important and have to be watched very, very meticulously. Drug treatment. We are coming to the last part. Drug treatment of PCOS for this girl. I'm not going which where. We know these preparations. Combined COCP plus metformin and anti-androgens. I'm not going into these dosages because you must have been taught so many times about all this. You know it. So, but these are the drugs which are used, and as per the case, you can do it. While going away from menstrual challenges, a gynecologist also, I face it, and therefore you must also be facing it. A depressed adolescent so often comes. Maybe trivial, maybe genuine reasons. This is a reality of life. Nobody previously had money and time to think about these type of problems in their children. Now we have. The society is coming up, so these type of children are coming now. A very concerned parents anxiously nearly burst into my consulting room with their timid-looking, fearful girl, adolescent daughter. Sir, she remains so depressed and anxious these days. What is the problem? I asked in a very confidence-generating tone to that girl, Beta, what is the problem? And now, thankfully, many of them, I am of their grandfather's age, so they become very confident, very comfortable. Because they say that grandparents and grandchildren are great friends. Why? Because they have a common enemy. And you know what enemy that is. Oh, sir, now see this girl, what she is telling me. This is a reality. Oh, sir, I stood second in class. This time, I always stand first. How will I get admission in a good branch? I asked her, Beta, what class are you in? Sir, I am in 9th standard. 9th standard. 9th standard, where we didn't even have time to think of these things. Here is a girl, and this is a reality. I'm not running her now. This is a reality. Depression and anxiety are major concerns in adolescents. often exacerbated by academic pressure, social media, and body image issues. This is very real. Eating disorders like anorexia nervosa and bulimia are twice more prevalent in teenage girls than in boys. So be aware of it, because I'm covering the spectrum of these adolescent disorders, not necessarily gynecologists. These are real. They may come to you as gynec problems. They may come to you as gynec patients, but the root may lie somewhere else. And just before leaving, I would like to tell you, this is what your wife tells you or your friends used to tell. Have you taken the keys? Have you taken your mobile? Have you taken the pen? And people like me jovially used to loudly say also to my children, have you taken your brains? So this is what, just before we leave, comprehensive health education, educating them on nutrition, hygiene, and reproductive health. Now you will have to discuss this. Nothing wrong in teaching how to dispose of sanitary napkins and teaching the boys, the male members, that menstruation is a reality, and if they see it, how to handle it in their classmates who are adolescents. I remember when my daughter, the elder one, was in her class, she was adolescent, started menstruating. She used to carry 2 sanitary napkins in her pads in her bag. Once I asked her just like that. Usually we don't see her bag, but I saw her packing. And she said, Baba, in case I get a menstruation during my class, I have 1 pad. But if one of my friends get it and she doesn't have, this is the education which we all have to impart to our children, daughters, and adolescent girl patients. Mental health support, open dialogue, counseling, and early intervention is very much necessary. They are vulnerable now. They have time to think about their brain and their reality. We had time only to think of study. Now they have much more. Regular screenings for iron levels, nutritional status, and mental health screenings, promoting healthy lifestyles, encouraging balanced diets, and regular physical activity. The generation above us were completely focused on independence. I remember my father told the only son of a widow, when he was arrested in the independence movement, and my grandmother Dadi, we call Dadi, went. She said, don't cry. You are not my mother. I have come to the jail for my mother. That was that generation. Our generation, bringing India up, a liberated India up. And the next generation, now this is the time they have to be taught about encouraging balanced diet and regular physical activity. That time there was only whatever food available you take. Who cares? Now no, we care. It matters, beta, balanced diet and healthy diet right from adolescent days. So friends, I have been given 40 minutes. I have completed 36 minutes, 44 seconds. And we'll just take 1 minute more. Old and new are coexisting in adolescent menstrual problems. What is important? Old also is there. New things have also come. I have introduced them to you. But the clear picture is having an eye on your fundamentals. And for keeping your fundamentals fresh, such sessions are required. I have worked very hard. I have 4 sessions this month. Maximum, not only because Durgadas and so many Niba and Amrish and all these names I saw, even Bharti and Rajeshri and all. Not because their names were there, but because this topic is such. I have really worked hardest among all the 4 topics which I'm going to cover. 1 is already over. This is the second one this month. Because fundamentals have to be very clear. When to use which progesterone? When to call it as an abnormal pattern? When to call it as, no, yes, you require help. When to make her consult a hematologist? These are the fundamentals. And therefore this session. And that is where a helping doctor is of great help in handling adolescents scientifically and with confidence. Because we have to remember that
पंछी बनूं उड़ती फिरूं मस्त गगन में, आज मैं आजाद हूँ दुनिया के चमन में। पंछी बनूं उड़ती फिरूं मस्त गगन में, आज मैं आजाद हूँ दुनिया के चमन
thank you very much. Thank you so much. God bless you all. God bless.
Thank you very much, sir.
Sheetal madam.
Yes, sir. Thank you, Dr. Pankaj Desai, sir, for that enlightening and insightful presentation. Your expertise and practical perspectives have truly enriched our understanding about this important subject. May I now request Dr. Sheetal Talekar, ma'am, to share her valuable insights, please.
I think she must be busy. Sir, from KSOGA, this is the only word I can express. One of wonderful teachings, sir. From the basics you have taken. Everything, even each and every sentence was a carry-home message for all of us who attended. And KSOGA really pays the gratitude for your presence today. Thank you very much, sir.
God bless you. God bless you.
I request Dr. Rajarshi Palladi, our president-elect, to say a few words.
Sir, it is without doubt to accept the teachings of Pankaj Desai, sir, that every word is so carefully curated and the carry-home and take-home message conveyed is so excellent that we always look up to his messages, what he has to research into and then carefully, give us the practice points that it was so very imperative to stress upon the points that randomly the girls are being diagnosed as PCOD just on the basis of ultrasound, and to demarcate the 8 years time after attaining their menarche is so very important, and not just label them as PCOD, because PCOD now is like every other girl comes to the hospital and the girls themselves know that there is something like PCOD. So much is the wrong message and information which has been confirmed. And thank you so much, sir, because the adolescent girls today are going to frame the future of tomorrow. And it's so very nice that you chose such a topic, and catch them young and teach them right is the message that we all got today. Thank you so much.
Thank you, Rajashri.
Durgadas, will you permit me to leave? Because
yes, sir. Yes, sir. Thank you very much.
Everyone, Amrish, Rajashri Madam, Bharti Madam, everyone. God bless you all.
Thank you so much, sir.
Thank you, Suvarna. Thank you.
We expect you to see physically in Karnataka once, sir.
You call, I will come. Karnataka, Amrish knows. Even at the drop of the hat, I will come. My heart is in Karnataka. My children are in Bangalore. From US they have shifted there. So Karnataka is my heart any day. God bless.
Thank you, sir. Thank you.
Yes, sir. Hopefully in the near future we will definitely have more programs.
Karnataka, madam, Amrish knows it. I'm honestly telling you.
Yeah.
He has got me at the shortest notice. I will come.
Thank you, sir.
Thank
Thank
you.
you.
Thank you. Thank you.
Now I request, I'm very much thankful to Dr. Neeraj Yadav. He was so busy. Then I told, at least for the last part, please join us and give your valuable talk. Now I request either Dolly Gupta is there?
Dr. Dolly Gupta. Arun CV, please. Dr. Dolly Gupta is the chairperson, but she had to rush for an emergency.
Yeah.
But we're very thankful that she accepted our invitation. Madam is the treasurer of Dog Society and currently the honorary secretary as well. But unfortunately, she is not able to join in. So I would take the privilege of introducing Dr. Neeraj sir. It's indeed a privilege to me, given by Durgadas sir, to introduce Dr. Neeraj. Neeraj sir is a Vice President-elect of FOXY 2027. Sir was a chairperson of Sexual Medicine Committee in 2020-23, and he has also got the winner of the Best Committee FOXY Award. He has been the past Vice President of Rajkot
That's fine,
Medical
Dr.
Society.
Srimati. It's okay.
Sir, a long list of accomplishments, sir. Of course, we are very fortunate, as Durgadas sir said, that you have accepted our kind invitation to join us on this platform and give us valuable insights. And I think it's a great topic, psychosexual intervention and sexual dysfunction, because we do come across lots of couple having sexual programs, lots of unconsummated marriages, and lots of concerns in this AI era. So I think we are really looking forward to your insightful talk. So thank you very much again, sir.
In
Thank
one
you,
word,
Dr.
wonderful friend. Wonderful friend. That's what I can say. Only one word of introduction. Over to you, sir.
Thank you, Dr. Srimati, for your kind introduction, and thankful Dr. Durgadas. But you have given me so donating task, because after Pankaj sir, it's very difficult to match his charisma and to fill up and keep the audience glued to the talk. But I will try my best. So let me share my screen.
I know you are a master in this field. That's the reason we have chosen you.
But compared to Pankaj sir, I have nothing. So thank you, KSOGA and Durgadas sir, for giving me this opportunity to talk about a topic that is very much less discussed. That is a psychosexual intervention in a sexual dysfunction. So I hope my slide are moving and voice
Yes,
is
sir.
okay. Okay,
Yes,
thank
sir.
you. So let's talk about the sexual health and some of the points related to it. Sexual health is a multidimensional. Sexual disorder often have a psychological and emotional roots. As a gynecologist, we often focus on anatomy, hormones, and pathology, but the sexual functioning is strongly influenced by emotion, self-esteem, relationship dynamics, and also important are the past experiences. So understanding this aspect allow us to provide truly comprehensive care and help couple to reclaim the confidence in their sexual life. So what is sexual dysfunction? The term sexual dysfunction refer to various problems that prevent individual from experiencing satisfaction during the sexual activity. This can manifest in multiple ways, including difficulty with the desire, arousal, orgasm, or pain intercourse in female, while erectile dysfunction, low desire, or premature ejaculation in male. It can affect anyone, regardless of age or gender. So, sexual difficulties are highly stigmatized in many cultures, including ours, and it's sometimes really difficult to open up about the issue when a couple is facing in their sexual life. So it leads individual to internalize the problem, and this often result in a feeling of being broken or inadequate, particularly when the issue affects the intimacy. So we need to integrate psychological screening into our routine gynecological care. And my sincere request to everyone, please start taking interest in the sexual medicine, because we as a gynecologist have a much bigger role to play in the sexual health of the couple. So psychosexual intervention for sexual dysfunction, it integrates psychological, relational, and behavioral strategies to treat the disorder, often rooted in the performance anxiety, stress, or interpersonal conflict. And these interventions are increasingly recognized as a primary treatment or sometimes adjuvant treatment for the sexual dysfunction. So here are the common psychological intervention which is given to the couple. That is a cognitive behavioral therapy, sensor focus therapy, then there is a mindful based therapy, then there is a psychoeducation, and the couple or relationship therapy. So let's discuss one by one. So whenever couple comes to us with any problem related to their sexual life, first step is the counseling. And there are many models available for the sexual counseling. Implicit is one of them. It is a 4-level clinical framework used by healthcare providers to address the sexual concern. P stands for the permission. At this stage, the clinician gives the client permission to talk openly about their concerns, while the client also permits the doctor to explore the sensitive areas. For many couples, this permission itself is sufficient to reduce anxiety and to normalize the sexual difficulty. Like sometimes a husband can have a problem concerned about the masturbation, or there can be need for the manual stimulation to achieve the erection in elderly, especially in elderly men, can be resolved simply through reassurance or by talking to the patient. Then LI stands for the limited information. Some problem can be addressed with the accurate focus information. For example, explaining that the prolonged foreplay often enhances the lubrication in women and can reduce the dyspareunia as well as solve the orgasm problem. Then SS stand for the specific suggestion. Here, the tailored strategies are given to the manage specific dysfunction, like a stop-start technique for the premature ejaculation. Then comes the IT, that is a intensive therapy. This is the most specialized level, and it is required in only 5% cases of the psychogenic sexual dysfunction. And it's demand advanced training in sexual therapy or psychotherapy. Rest of the therapy, first 3 permission, limited information, and specific suggestion can also be given by us as a gynecologist, though it's not very difficult. Only in some 5% of cases you require some psychologist or psychiatric help. So let's come on the sensory focus. Sensory focus therapy involves a graded series of non-demand sensual touching exercise. Typically used with the couple, the objective of the sensory focus therapy is to reduce anxiety and avoidance of the sensual touching or sexual activity, to improve the sexual communication between partner, and to improve intimacy by reintroducing the sexual activity in a gradual way. Sensuous focus is about touching and being touched. There is 2 distinct activities. You can maximize the potential of sensory focus by beginning without preconceived notions or of what you will experience, how it will feel, how much pleasure it will produce. So there are so many thoughts in the couple's mind. In other words, begin with an open mind so as not to color your experience and feeling. Try to avoid being judgmental or too evaluative. Judgmental thinking boxes us in like what is good, is it boring, it is ecstatic, and judgmental thinking that occurs as sometimes something is happening, not when it is over, is even more self-defeating as it puts you in the position of being an observer rather than a participant. Observing brain are blocked from the experiencing, and they think too much and they feel too little. So instead of judging or evaluating, tries to simply be and to experience the thing. Notice what is happening in terms of physical feeling by simply noticing how your partner's skin feel like smooth, rough, warm, moist. You avoid evaluating and are able to simply focus on the experience itself. It is generally conducted over 6 to 8 sessions, with each session lasting for about an hour. At the initial visit, the couple is introduced to the overall technique. They are taught specific exercises. After 4 to 5 practice sessions with the same technique, they return to the therapist, and usually after a week. During the follow-up session, the therapist seeks feedback whether the couple actually practice, whether they feel comfortable about it, what their experience was like, and if they are ready to continue it or not. And if the therapist is satisfied that the couple has performed the technique correctly, then they are introduced to the next technique. In practice, about 3 to 4 sessions are required for sensory focus, and another 3 sessions are usually devoted to address the specific sexual problem. So there are various phases in the censored focus therapy. Initial phase, the process of censored focus typically begin with the non-sexual gentle touch. Partners take turn exploring each other's body, focusing on sensation rather than the sexual performance or gratification. And this phase aims to create a safe and comfortable space for both individuals to express their need and desire without being judgmental. Ideally, both partners are undressed, showered, and free of watches or any other jewelry. Designate one partner as a toucher and the other partner as a receiver to get the thing started. This is how the censored focus therapy started. The receiving partner should primarily focus on their own sensation while being touched. For the moment, they are not to reciprocate touching. Instead, the receiver should simply notice the sensation, not in terms of evaluating or analyzing them, but experiencing the touch fully. So here focus is about the experience of the touch. Then the receiving partner should, however, speak up only if the touch does something physically or psychologically they feel uncomfortable about it. It is usually recommended that this touching continue for at least 15 minutes, especially since in the beginning it may seem a bit awkward or unnatural, and a few minutes might be needed to get past the initial strangeness. On the other hand, we urge touching not to be prolonged to the point of boredom or to fatigue to the other partner. Then after non-genital touch, then there is a progression to the sexual touch. As couple become more comfortable, the exercise progress to include the sexual touch. The emphasis remains on the sensory experience rather than achieving any specific sexual goal. And this helps to build trust and emotional connection, potentially leading to a deeper understanding of each partner's desire and preferences. In this step, the breast and genitalia are included in the exploration. Kissing and intercourse are not allowed in this stage. The basic guidance for this step 2 is the same as before: privacy, nudity, cleanliness, etc. And to begin, one person should be designated as like previous session toucher, and the one is as a receiver. It is often advisable for receiver to start on lying face down position to start the process. The point is not to try to be turned on or to make something happen for your partner, but to pay attention to your own sensation in the context of the exploring your partner's body as a sensual, sensory, tactile experience. Then comes the third stage, that is a mutual touching. Now it's time to extend the scope of the touching experience by removing artificiality of your turn and my turn. This gives each person's opportunity to use their newly improved sensory awareness to focus simultaneously on the sensation from touching your partner and on the physical sensation of your own body resistant from the being touched. Then comes the sensual intercourse. So please see that it is not sexual intercourse, it is a sensual intercourse. In this version of the censored focus, you extend the gain made in the emphasizing your awareness of physical sensation into the realms of the genital contact. Here again, the goal is to discover what is interesting and what is a pleasurable feeling about the being intercourse. So it's about the sensual intercourse. It's not a sexual intercourse. It is more about the perceptions of what your sensation is giving you. And ultimately, communication and feedback. Throughout the censored focus therapy, communication is the key. Partners are encouraged to openly express their feeling, desire, and their boundaries, and because this facilitates the better understanding of each other's needs and promote a sense of emotional closeness without the being judgmental. So after the sunset focus therapy, second psychosexual therapy is the cognitive behavioral therapy. CBT is a structural and goal-oriented form of the psychotherapeutic treatment which provide a non-pharmacological approach toward the treatment of the sexual dysfunction. The main focus of CBT in sexual dysfunction is to address the negative thought patterns causing the sexual dysfunction, improving communication, and providing a supportive environment. For sexual health, there are basically two components. One is the cognitive component and one is the behavioral component. What is cognitive component? In reference to the sexual health, cognition refer to the beliefs and thoughts of the person toward themselves, toward their partner, and toward the sexuality. Cognitive distortion can be negative thoughts about their body image, about the sexual performance, and about their self-worth. So cognitive component can negatively affect the sexual performance or sexual satisfaction. Then second component is the behavioral component. Avoiding sexual activity and physical intimacy, seeking extraordinary reassurance in the relationship, and over monitoring their performance comes in the behavioral part of the this component. According to their judgment, this can reduce their anxiety and embarrassment. But however, such behavior can give them comfort for short duration of time, but it can cause a sexual dysfunction in a longer term. So intervention of CBT are structured around the following components. First is the identification of the problem and amendment of the maladaptive sexual or cognitive thoughts. Strategies to reduce the performance anxiety, improvement of the communication and emotional intimacy, development of the practical and realistic expectation about the sex, because sometimes couple may have a unrealistic CBT is try to convert it into the realistic goal, and restructuring the sexual behavior to focus more on the pleasure rather than the performance. So what is cognitive restructuring? Cognitive restructuring helps in identification of the irrational and self-repeating belief and help the individual in rephrasing this belief, which can further reduce the stress associated with the sex. Like irrational thought can be, if I can't maintain an erection, my partner will lose respect for me. So what we try to give them that erection difficulties do not define my worth or masculinity, and occasional erection difficulties are common. So by restructuring that cognitive belief, we can manage their erection problem. Then addressing the core belief. CBT encourage client to recognize the deep-seated scheme like guilt, shame, and restrictive attitude toward the sexual activity and replace them with the more positive sex affirming belief. Like some individuals can have a belief that it is wrong to express the sexual desire. So what can be cognitive reframing? Desire is a natural part of loving relationship which should be enjoyed by every person. So by changing the core belief, we can cure many sexual problems. Then third part is the mindfulness therapy. Mindfulness is a conscious state of acceptance and present moment awareness without being judgmental. It was rooted in the Buddhist Vipassana meditation. Mindfulness-based therapies focuses on the cultivating acceptance, curiosity, and openness to experience, allowing negative emotions to pass without attempting to change them. Mindfulness can help individuals in several ways, like by focusing on the present moment, it reduces the worries about the future outcome during the sexual activity. The non-striving aspect of the mindfulness encourage letting go of expectations and the goals and promoting a more accepting attitude. And no judgmental acceptance allows individual to appreciate their current experience even if it doesn't meet the desired level of sexual function, reducing the pressure to perform and promoting a more positive experience. Senses focus and mindfulness meditation share similarity in their focus in the present moment sensation and reducing the self-monitoring. But there is some difference. Like mindfulness can be practiced individually, making it accessible to those without the partner or who have an anxiety issue, wherever sensate focus require a partner. Additionally, mindfulness encompasses a broader range of attention target, like including breath, body sensations, and thoughts, where sensate focus is primarily based on the touch sensation. Then last part about the psychotherapy is the couple therapy, where we teach the couple about the better communication, because good communication is essential for the healthy sexual relationship. This therapy teaches couple how to express their need and boundaries clearly and reducing the misunderstanding between the couple. Tackling the relationship challenges, because sometimes sexual problem can create conflict within the couple. So by couple therapy, we try to change that. Sexual dysfunction is often tied to broader relationship issue like stress, trust problem, or emotional distances. So therapy helps couple to resolve this conflict, creating a more supportive environment for intimacy. There are practical exercises given. Then changing the negative thought is important for the couple therapy, and emotional support is also important in the couple therapy. Like couples therapy provide a space to explore these factors and develop coping strategies, helping couple to feel more connected and supportive to each other. So in summary, sexual disorders are deeply shaped by the psychological and emotional factor. Anxiety, mood, trauma, guilt, body image, and relationship all play the important role in the sexual health. So empathetic, holistic, and couple-oriented approaches are essential while managing the sexual problem. So our goal as a gynecologist is to rebuild the confidence in the couple, to reduce the shame about the sexual problem, and to promote the healthy sexual functioning to all the couple, so they can enjoy their life, because sexual health is very much important for the quality of life is also, and it should not be ignored. So we also should emphasize on to improve the sexual health of the couple whenever we get chance. Maybe during the they come for infertility, maybe they come in menopause period. We all should always ask about if they are facing any issue related to sexual health, and we should try to get help them. So sexual health is very much important. So don't ignore it. And thank you for your patient hearing.
Thank you, sir.
That was a wonderful talk, Neeraj.
Thank you.
Very nice.
It's a wonderful talk, sir. As you rightly told, we gynecologists are the first point of contact. And in our busy OPD hours, we neglect this. We are not taking time out of it. And if we make up our mind, we can touch their, not only the female, we can touch their family and do something good for the family, which is most important. As you are rightly told, the infertile couple or perimenopausal age, wherein the sexual activity, they are psychologically they are withdrawn. Like we have to encourage them to come out with the problems. Excellent deliberation, sir. Thank you, KSOGA. Thanks you a lot for coming and addressing us.
Thank you, Nikada sir, and best wishes to you for your coming election.
Thank you. Thank you. Srimati, thank you.
Yes, sir. Thank you, sir. So I think with that, we come to the end of this webinar third episode. We didn't have a panel discussion, as sir rightly said, because we wanted to have lots of time for these two talks, which are really very important. One covering the adolescent concerns, and two, obviously, oft neglected, not spoken about psychosexual interventions and sexual medicine. So I think we thank the chief guest who honored this episode, Dr. Vibha Mogan, Dr. Bharti Man, Dr. Jyoti Banglawala, who obviously couldn't join in because of her concerns of traveling, Dr. Rekha Ma'am, of course, our President-elect, Dr. Ashri ma'am, our Secretary ma'am, Dr. Shobha. I mean, all of these would not be possible without the brainchild of, this Dr. Durgadas sir. So we hope that we'll be able to do many more episodes. So we thank the Vapi, Vadodara and Ahmedabad societies for having joined hand with us. And we thank Pankaj Desai sir for his excellent talk, and of course Neeraj sir for giving wonderful insights. We thank the chairpersons, Dr. Sheetal and Dr. Dali, who couldn't join in, my co-moderator, Dr. Suvarna, and of course Arun, for being the backbone for everything. So with this, we'll be again coming soon with yet another episode. So we hope everybody would be able to join in and participate in this wonderful journey of learning. And of course, we wish Sir all the best, and we hope that your election would be very smooth, sir. We can only pray, and you'll definitely work towards it, sir.
Thanks to Amrish sir also.
Yes, Amrish sir,
support
for
for
having
Durgadas sir.
been with us throughout, sir. Throughout, sir. Thank you very much, sir.
Thank you very much.
Amrish, ಹೆಂಗಿದ್ದೀರಾ?